Musculoskeletal Pathology. Skeletal System. Number 1. Achondroplasia. Impaired cartilage proliferation in the growth plate, common cause of dwarfism due to an activating mutation in fibroblast growth factor receptor 3. Autosomal dominant. Number 1. Overexpression of FGFR3 inhibits growth. Number 2. Most mutations are sporadic and related to increased paternal age. Clinical features: short extremities with normal sized head and chest due to poor endochondral bone formation. Intramembranous bone formation is not affected. Endochondral bone formation is characterized by formation of a cartilage matrix which is then replaced by bone. It is the mechanism by which long bones grow. Intramembranous bone formation is characterized by formation of bone without a pre-existing cartilage matrix. It is the mechanism by which flat bones, for example, skull and rib cage, develops. Mental function, lifespan, and fertility are not affected. Number 2. Osteogenesis imperfecta. Congenital defect of bone resorption resulting in structurally weak bone. Most commonly due to an autosomal dominant defect in collagen type 1 synthesis. Clinical features: Number 1. Multiple fractures of bone can mimic child abuse, but bruising is absent. Number 2. Blue sclera. Thinning of sclera collagen reveals underlying choroidal veins. Number 3. Hearing loss. Bones of the middle ear easily fracture. Number 3. Osteopetrosis. Inherited defect of bone resorption resulting in abnormally thick, heavy bone that fractures easily. Due to poor osteoclast function. Multiple genetic variants exist. Carbonic anhydrase 2 mutation leads to loss of the acidic microenvironment required for bone resorption. Clinical features include bone fracture, anemia, thrombocytopenia, and leukopenia with extramedullary hematopoiesis due to bony replacement of the marrow. Myelopathic process, vision and hearing impairment due to impingement on cranial nerves. Hydrocephalus due to narrowing of the foramen magnum. Renal tuberoacidosis seen with carbonic anhydrase 2 mutation. Lack of carbonic anhydrase results in decreased tubular reabsorption of bicarbonates, leading to metabolic acidosis. Treatment is bone marrow transplant. Osteoclasts are derived from monocytes. Number 4. Rickets or osteomalacia. Defective mineralization of osteoid. Osteoblasts normally produced osteoid, which is then mineralized with calcium and phosphate to form bone. Due to low levels of vitamin D, which results in low serum calcium and phosphate, Number 1. Vitamin D is normally derived from the skin upon exposure to sunlight 85% and from the diet 15%. Number 2. Activation requires 25 hydroxylation by the liver followed by 1 alpha hydroxylation by the proximal tubule cells of the kidney. Number 3. Active vitamin D raises serum calcium and phosphate by acting on intestine, increase the absorption of calcium and phosphate. Kidney, increase reabsorption of calcium and phosphate. Bone, increases resorption of calcium and phosphate. Vitamin D deficiency is seen with decreased sun exposure. For example, northern latitudes, poor diet, malabsorption, liver failure, and renal failure. Rickets is due to low vitamin D in children, resulting in abnormal bone mineralization. Most commonly arises in children less than 1 year of age, presents with pigeon breast deformity, inward bending of the ribs with anterior protrusion of the sternum, frontal bossing, enlarged forehead due to osteoid deposition on the skull, rachitic rosary due to osteoid deposition at the costochondral junction. Bowing of the legs may be seen in ambulating children. Osteomalacia is due to low vitamin D in adults. Inadequate mineralization results in weak bone with an increased risk for fracture. Lab findings include less serum calcium, less serum phosphate, more PTH, and more alkaline phosphatase. Number 5. Osteoporosis. Reduction in trabecular bone mass results in porous bone with an increased risk for fracture. Risk of osteoporosis is based on peak bone mass attained in early adulthood and rate of bone loss that follows thereafter. Peak bone mass is achieved by 30 years of age and is based on number 1 genetics, for example vitamin D receptor variants, number 2 diet, and number 3 exercise. Thereafter, slightly less than 1% of bone mass is lost each year. Bone mass is lost more quickly with the lack of weight bearing exercise, for example, space travel, poor diet, or decreased estrogen, for example, menopause. Most common forms of osteoporosis are senile and postmenopausal. Clinical features: bone pain and fractures in weight-bearing areas such as the vertebrae leads to loss of height and kyphosis, hip and distal radius. Bone density is measured using a DEXA scan. Serum calcium phosphate, PTH, and alkaline phosphatase are normal. Labs help to exclude osteomalacia, which has a chemical clinical presentation. Treatment includes exercise, vitamin D, and calcium limit bone loss. Bisphosphonates induce apoptosis of osteoclast. Estrogen replacement therapy is debated, currently not recommended. Glucocorticoids are contraindicated, worsen the osteoporosis.